So I grew up where the whole family used to sit down on Saturday night evenings and watch the movies together. And I've always thought when someone comes up to the front like this, I should say, it is that time, ladies and gentlemen, to turn the lights down low and put your feet up. And I hope you enjoy the show. So without further ado, let me talk a little bit about important pitfalls in oncologic PET CT. In terms of disclosures of commercial interest, I serve as a consultant for In Vitro, which is a Konica Minolta company, and the Center for Probe Development and Commercialization. Otherwise, I have no financial relationship with a commercial organization that may have a direct or indirect interest in the content of this presentation. I thought I might start out with a few basics in terms of sort of PET tracers, detectors, SUV biodistribution, recommendations for patient preparation, although we've already discussed a lot of them, but I'll just emphasize a few things. And then we'll talk a little bit about some variants, benign pathologic processes, blind spots for image interpretation, and then maybe a few illustrative examples. All right, so whenever I think about oncologic PET, I think about all the radiopharmaceuticals we have available to us. Now, I must admit, in this particular talk, I am going to stick primarily on FDG, but let me mention a few and let me discuss why. So, whatever you do, and it's becoming more and more important nowadays, you want to think about, at the end of the day, why is the patient being referred to you, and what does the clinician actually want to know? And therefore, what might be the best radiopharmaceutical to use? So I show FDG versus FLT in a couple of cases of mantle cell lymphoma, one in particular here, just to illustrate that although we really don't use FLT these days because FDG is more intense, typically at sites of disease, if we are looking for response assessment, and you'll get more talks on that later in the day, it can be helpful to use a different radiopharmaceutical that might show the response better. So this is just illustrating that at baseline, your FDG is more intense. So if you were looking for the total extent of disease, you'd probably pick it up better using an FDG PET rather than an FLT PET. But if you wanted to look at the change related to your therapy, in this case, the FLT shows it far better than the FDG. So the question is, what do you really want to know? This is a first man in Canada who was scanned with DCF-PYL who had castrate-resistant prostate cancer. It was a bit of an older scanner, but basically what you could see was the disease that would jump out at you from across the room, which was so beautiful. And as Phil very nicely spoke earlier today, we've also got a slew of radiopharmaceuticals that are now available for imaging the brain. These came through probably 2013, 2014, that sort of ballpark. And the only reason we don't see more of them in clinical practice is because we just don't have good tools to treat dementia yet. I have high hopes that we will have one shortly. I really hope the Trailblazer trial reads out well for us all. We probably won't have those results for another 12 months. But breakthroughs will be on their way.